me, and it's always a pleasure for me to be among all of you. And, I have been coming to this session for the last 3 years, last year and year before. The overwhelming number of attendees and the participants it actually indicates the successful happening of this event. I congratulate the organizing committee, and I also appreciate the participants and attendees for their lust for and desire for seeking the knowledge and updates. The topic assigned to me was a bit complex today. I'm sorry for being in a low profile today. I was actually suffering from fever for the last 2 days, and I've just taken paracetamol. I'll try to be crisp and brief as Professor Najmun was. The treatment choices in hypertension, one common topic and our day-to-day life in our clinical practice. Our practice is full of dealing with the people who are having different presentations for hypertension. We are dealing with there are so many aspects of hypertension which we are dealing in our day-to-day practice. That this topic is always more and more demanding to create our knowledge. What is the evidence versus conventional opinion? High blood pressure is still the leading cause of death worldwide. And it claims almost 9.4 million deaths per year among the 1.64 million hypertensive patients. And the incidence of hypertension has doubled in the last 5 years in all social strata. Unfortunately, only 13% of these hypertensive patients achieve adequate blood pressure control. Hypertension is responsible for at least 45% of deaths due to heart diseases and 51% of deaths due to stroke. Although we have limited data available in Pakistan, but the 2017 statistics which were published in the Journal of Epidemiology and Global Health it indicated that almost 23 million Pakistanis are suffering from hypertension. It's very unfortunate that 11 million people who were surveyed were diagnosed cases of hypertension, whereas 12 million were undiagnosed. They were running hypertension, but in fact they didn't know that they were hypertensive. And only 2.3 million people among these 23 million they were having their blood pressures under control and according to the target levels. Which means that 90% of hypertensive patients in Pakistan, they are either undiagnosed, they are untreated or uncontrolled. What treatment we should choose for hypertension? हमारी choice क्या होनी चाहिए? We should be choosing therapy which actually leads to cardiovascular risk reduction. Should be should be having good tolerability for the patient, and therefore it will lead to better adherence. It should be providing more optimal and round-the-clock blood pressure control and a good office blood pressure control as well. Whatever the treatment goals for hypertension are available in NICE guidelines, the European Society of Hypertension. I was a member of the working group on hypertension guidelines the last year in 2018 when the guidelines were declared in Germany. The essence of all these guidelines is actually not the blood pressure control. The essence is blood pressure control as well as the cardiovascular risk reduction. So this is not a number game actually. We have to deal with the blood pressure reduction as well as decreasing the cardiovascular risk which these people are subjected to. There are so many therapies available for treating hypertension. The effective treatment for hypertension, the desirable combinations which are available, these solid green bars, these indicate the preferred choice for blood pressure control treatment. The dotted are possible or alternative treatments, and the red should be not be used in the clinical practice. So thiazide diuretics can be combined with ACE inhibitors. The thiazide diuretics can be combined with ARBs, angiotensin receptor blockers. Calcium channel blockers can be combined with both angiotensin receptor blockers or ACE inhibitors. Similarly, beta blockers can be combined with ACE inhibitors, can be combined with calcium channel blockers. And the alternative treatments are also available. Importantly, the angiotensin receptor blockers should not be combined with angiotensin converting enzyme inhibitors. This is a class 3 indication actually. This is the essence of the 2018 European Society of Cardiology guidelines, which were published in, which were declared in Germany in 2018, last year. So, combination regimes were actually the fixed drug FDCs, fixed drug combinations, which were to some extent according to physician's choice and according to physician's desires were practiced before. So these were brought in black and white. So FDCs, fixed dose combinations were encouraged or recommended in the European Study of 2018 guidelines. Importantly, the fixed dose combinations are recommended for those hypertensive patients who are having their blood pressures, systolic blood pressures more than 20 millimeter of mercury beyond their target levels, and the diastolic blood pressures more than 10 millimeter of mercury beyond diastolic levels. For these specific group of patients, we can go with two drugs right from the beginning, and single pill combination is preferred. So the initial therapy should be a dual combination which comprises of ACE or ARBs with calcium channel blocker or diuretic. So ACE with calcium channel blocker or with diuretic, and ARB with calcium channel blocker or diuretic. Consider monotherapy, especially as I have already told you that this is a choice for those who are having their blood pressure targets beyond 20 millimeter of mercury according of their desired or target systolic blood pressure, or 10 millimeter of mercury beyond their diastolic blood pressure goals. For all those who are not according to these, who are not under these criteria, monotherapy should be preferred. As a step 2 treatment, we can combine ACE inhibitor or ARB with calcium channel blocker and diuretics. Please note this is or, but this is plus. So step 2 treatment we have diuretics, and as a step 3 treatment. So till step 2 treatment we prefer single pill therapy, monotherapy, just to improve the adherence of the patient with their treatment of high blood pressure. At step 3, when blood pressure is not under control, we can advise 2 pills, and this second pill may be spironolactone 25 milligram or 50 milligram once daily, or any other diuretic or alpha blocker or beta blockers. Beta blockers can be added as an escalating regime for titration of therapy in poorly controlled hypertensive patients, or especially those hypertensive patients who are having compelling indications of beta blockers, like who are having congestive cardiac failure or who are having ischemic heart disease. So there is always a dilemma on what to choose, an ACE inhibitor or ARBs. Are there any significant differences among RAS inhibitors? RAS inhibitors were initially, basically these were 3 group of drugs: angiotensin receptor blockers, angiotensin converting enzyme inhibitors, and direct renin inhibitors. The direct renin inhibitors are no more in use these days. However, ACE and ARBs are widely being used. What is the comparison and what is the evidence of these 2 groups? So, ACE are more effective on myocardial infarction, cardiovascular, and total overall mortality. The reasons I will be showing in the upcoming slides. So this is a study in angiotensin converting enzyme inhibitors reduce mortality compared to angiotensin receptor blockers. Systemic redundancy was published in the Preventive Journal of Preventive Cardiology. The difference may be a result of the higher concentration of bradykinin with the use of ACE inhibitors by virtue of their cardiovascular properties, and not on the reduction of blood pressure only. As I already told you that this is basically not a number game. We have to focus on the cardiovascular risk reduction as well, and not only the control of blood pressure numbers. ARBs, this was a recently advanced concept which was called ARB-MI paradox. ARB, angiotensin receptor blocker, MI paradox. I would like to draw your attention to past 3 or 4 months happenings when there are so many withdrawals by the FDA of angiotensin receptor blockers. There are so many drugs which have been put under grey box warning, and certain other are being studied. So majority of these, interestingly, majority of these drugs were angiotensin receptor blockers. There was single ACE inhibitor as well in this group, but majority were angiotensin receptor blocker. And the reason was, the reason on global level was myocardial infarction paradox, which was increasing in those who are using angiotensin receptor blockers. So they do not reduce cardiovascular mortality, which is based on the risk of myocardial infarction, death, or total mortality. The Pakistan Hypertension League new guidelines which were published in 2018, they also endorse the international guidelines. ACE inhibitors are the category best suited for the initiation of therapy across most age groups. Not all individual trial or meta-analysis have observed the impact of angiotensin receptor blocker treatment on the incidence of myocardial infarction. So the combination therapy again, ACE inhibitor with calcium channel blocker was recommended in the Pakistan Hypertension League guidelines, and SCOT BPLA, the reference trial, as an alternative to ACE inhibitor. ARBs were also proposed in these guidelines. So adherence to fixed dose combination therapy with calcium channel blocker and ACE inhibitors was significantly greater than for free combination therapy, different polypill therapy. This is a basic concept for the mechanism of action regarding ACE inhibitors, and this indicates why the cardiovascular mortality is reduced by angiotensin converting enzyme inhibitors and not to the same extent by angiotensin receptor blockers. And this is basically the bradykinin metabolism. And the bradykinin metabolism is inhibited by angiotensin receptor blockers, but not inhibited by ACE inhibitors, and leads to increased levels of bradykinin in the blood. The positive or beneficial effects of bradykinin are vasodilation. We all know that vasodilation is always a positive concept for cardiovascular mortality and even the neurovascular mortality. So therefore, if we go through the pharmacology and basics of many of the antihypertensive drugs, majority are working on the vasodilating mechanism. So it leads to vasodilation, anti-fibrosis, anti-inflammation, and anti-thrombosis. If it is inhibited, the results are pro-fibrosis, pro-inflammation, and ROS production. Again, a repetition of the same slide. So bradykinin metabolism is not inhibited by angiotensin converting enzyme inhibitors, and it leads to positive effects. Importantly, this is also an important slide, and it indicates that the problem which is basically seen with angiotensin receptor blockers. So angiotensin receptor blockers are basically leading to increased level of angiotensin 2 in the blood, and this angiotensin 2 is responsible for vasoconstriction and apoptosis as well. So the apoptosis in coronary arteries, it may increase ischemia by excreting atherosclerosis, ischemia leading to increased risk of myocardial infarction as well as stroke. The perindopril is a well-known ACE inhibitor, and perindopril is known to have the most potent effect on raising the bradykinin level as compared to ramipril or other ACE inhibitors. The blood pressure efficacy of a fixed dose combination, blood pressure efficacy of perindopril in both the groups across the board, those who are having mild hypertension or those who are having severe hypertension, it is beyond any other antihypertensive. And what happens when it is compared with the angiotensin receptor blockers? So the perindopril in comparison with other ACE inhibitors or angiotensin receptor blockers, it leads to almost 27.6% reduction in myocardial infarction risk as compared to other ACE inhibitors or ARBs. Similarly, for all 10 by 5 mm of mercury blood pressure reduction, for all 10 by 5 mm blood pressure reduction, in comparison with ARBs, the mortality, the cardiovascular mortality is decreased in those who are treated with perindopril alone. So 25%. So blood pressure is controlled. So all the blood pressure, if in comparison with ARBs, if it is controlled by 10 by 5 mm mercury, as I already said, this is not only a number game. So the numbers are similar, 10 by 5 mm mercury, but the cardiovascular risk reduction is more with perindopril as compared to angiotensin receptor blockers. Perindopril allows rapid blood pressure control as compared to angiotensin receptor blockers. So what happens if we combine perindopril and amlodipine? There is more sustained blood pressure control, trough to peak ratio. The trough to peak ratio is basically a concept which indicates the overall and round-the-clock blood pressure antihypertensive effect of any drug. So the trough to peak ratio concept was advanced almost 4 to 5 years back. So what it means that when we subject a patient to a drug, and the half-life of of this drug is over, and since the time duration between this ending of half-life of first dose and the commencement of second dose, the commencement of second dose and then achievement of the peak level of antihypertensive effect of the second dose. So this duration is called trough to peak ratio. So any drug which is giving more than 50% control of blood pressure during this trough to peak ratio time, so this should be recommended for, or this should be preferred over other antihypertensive drugs. So you can see that the trough to peak ratio concept, treatment of trough to peak effect of perindopril as well as amlodipine is beyond any other antihypertensive. So very good trough to peak ratio response of perindopril as well as amlodipine, and what if we combine the both, we can achieve better results. Perindopril and amlodipine combination, when combined in all three groups, whether this is grade 1 hypertension, grade 4, grade 3, leads to reduction in blood pressure across the body. Again, the repetition of same concept, that it provides full 24-hour blood pressure control due to same reason that there is more trough to peak control of blood pressure with both perindopril as well as amlodipine. So we can achieve sustained systolic blood pressure response over 3 months period, not exceeding more than 30 mm of systolic mercury, and diastolic not exceeding more than 90 mm of mercury with perindopril and amlodipine combination. More effective decrease in night time. So night time, this is another concept of hypertension, that people who are having, these are called reverse dippers or non-dippers. Dipping is a physiological concept that blood pressure drops during sleep, and those who are having a paradoxical increase in blood pressure at night time, those are called non-dippers, or those are called reverse dippers or non-dippers. So those who are having nocturnal rise in blood pressure, they are subject to more cardiovascular mortality as compared to those who are having those who are having dipping. So the nocturnal or nighttime blood pressure control is more reliable in the Escort ABPM trial with amlodipine and perindopril combination as compared to atenolol or hydrochlorothiazide. Better control in central blood pressure. The central blood pressure is a concept that people who are having aging and who are having atherosclerotic disease, so the brachial blood pressures are not that reliable in these group of patients as compared to central aortic blood pressure, and the central aortic blood pressure is well controlled with perindopril and amlodipine as compared to any other antihypertensive combination. So there is less blood pressure variability. With less blood pressure variability, you can see these are the spikes which indicate excessive blood pressure variability, and these are less with them and perindopril combination as compared to other antihypertensive drugs. So blood pressure reduction, 31% blood pressure reduction, and positive effects in all group of patients: new onset of diabetes, stroke, renal impairment, peripheral arterial disease, cardiovascular reduction. So these all arms are being covered in the Escort trial by this combination. So we believe in endothelial integrity, which is achieved by ACE inhibitors, and we believe in smooth muscle dilatation or vasodilatation, which is achieved by calcium channel blocker, and we combine the two, we can have both flavors. Synergy leading to reduced secondary effects. Secondary effects means the unwanted effects of calcium channel blockers like amlodipine. People who are having single monotherapy with monotherapy treatment with calcium channel blocker amlodipine, they are subject to peripheral edema, and this is the most common reason for withdrawal of this medicine. If we combine amlodipine with ACE inhibitor like perindopril, we can have 54% reduction in the incidence of peripheral edema with amlodipine alone. So there is a wealth of data, wealth of trials available on ACE inhibitor and angiotensin receptor blocker. I will not go into much detail. This is the important slide. Blood pressure indication, hypertension treatment covered by perindopril, amlodipine, yes. Valsartan and amlodipine combination, yes. Olmesartan and amlodipine combination, yes. Telmisartan, yes. Indication for coronary disease, yes, with amlodipine and perindopril, but not with any other combination. Cardiovascular evidence, Escort trial was available for this combination. Recently, there is a on-target trial available with telmisartan and amlodipine, but unfortunately missed this. So better hypertension control, coronary disease indication, cardiovascular protection, round-the-clock blood pressure, central aortic blood pressure control, nocturnal dipping, all positive effects achieved by perindopril and amlodipine combination. ACE inhibitors, while we are prescribing an ACE and ARBs, we should be looking beyond blood pressure control or the numbers. Thank you so very much for your time.